the risk of perforation becomes
Hi, good
quite
evening, Dr. Smith. How are you?
Sir, good evening, sir. Absolutely fine, sir.
Great to see you.
Sir.
The
Good evening,
stethoscope
Smit,
looks
sir.
nice, Smith. You are in office.
Hi.
Sir, I was a bit
How are
late
you?
today, sir. So I'm still in my clinic.
Great, great.
Good evening, sir. Good evening, Smit, sir.
Good evening, dear. How are you, Raghu?
Good.
Long time.
Fine, sir. Fine, sir. Fine, sir. Sir, good evening, Sunil, sir. Good evening, Ajay, sir. Good evening, Naveen, sir.
Hi, good evening, Dr.
Yes, sir.
So we can start, sir.
I think, Smith, we can start now.
Yeah, we can start, sir.
Yeah, Dr. Sunil, all yours. Yeah.
Sir, so
If you have any difficulty in sharing, we have the technical person here also.
it's okay. I think
Yeah, we can see your screen. Absolutely.
okay. Okay, so this is regarding one of the mechanical complication after MI that we many a times these patients die before being anything is being done. So this was one survivor. This was a 55-year-old male. He has history of old CBA, left hemiparesis. He presented with 7 days of on and off chest pain and 30 minutes of severe chest pain before he presented here. And for 7 days it was on and off, sometimes very high. And last 30 minutes he complained of severe chest pain, acute dyspnea. He was drowsy, diphoresis, and tachypnea. He had all cold peripheries, pulse and BP was unrecordable in trauma. ECG was suggestive of acute ST elevation inferior lateral wall MI. So in trauma itself, they gave loading doses, NIV support was started, inotrope they started in trauma, and then thereafter patient was shifted to CCU. In CCU, when we did an echo, there was a large heteroechogenic collection in the pericardial cavity, and it was looking like some organized echogenic mass compressing the right ventricular cavity, giving rise to tamponade. Look like organized clot. Only problem was it was since the patient had 7 days of history, so just effusion would have been a little tricky to think of what it is. So RV side, the issue was liquid phase was only 6 to 8 millimeter, and there was a echogenic mass on. It looked very organized clot over all over, not only right ventricular but on left side also, and the liquid phase was about 6 to 8 millimeter. However, overall the total was more, around 18 to 20 millimeter. So thought of possible cardiac rupture, and so now I have a few queries because that was a case some 4 or 5 years back. I have a few queries in this case, maybe something whether to tap this case or not. What is the role of IABP, and what is the role of angiography and LV angio for rupture? Because a similar time one Elnigen case report was there where they did CAG and tried to prove that there is a rupture with LV angio, and during LV angio injection the rupture again, like it was a stable rupture that give way and the patient died on table. So I'd like to know what is the opinion of others in whether we should tap it or not, because the liquid phase was only 6 to 8. What is the role of IABP and CAG? CAG was a controversial thing that with literature search, I was still not clear whether to do it beforehand or afterwards. So, hello.
RV side fluid is so less.
Yeah.
I said the RV side fluid is so less that it is almost untappable. And secondly, there's an organized clot. I think this rupture was a couple of days old, maybe. It wasn't possibly a recent rupture. Otherwise, there would have been no organized clot. It seems to be a little bit old. So tapping may not yield enough benefit. That is what my idea is. IABP, yeah.
6 liquid phase was very less, 6 to 8
Yeah,
millimeters.
that's
That's why I thought not to tap anyway. And what if like liquid phase is not there, because we got similar cases also, where liquid phase is only there, no organized clot. In those situations, sir, what will be your approach?
So as a last ditch effort, you can put in a catheter, but it really won't help because if there is a rupture, there'll be a continued, egress. In fact, you just might increase the, effusion. I don't think it really helps much.
So
have to-
one of these
Yeah.
was like, if I tap it, like in this case, it was different. But sometimes we get other cases where organized clot-like structure is not there. This is whether tapping that thing reduces the pressure in the pericardial cavity, and whatever clot is formed, it may give way, and again there will be bleeding that we cannot help.
That's what I'm saying. If there's an ongoing rupture, I mean, whatever you do, tapping or even if you tap, that free wall rupture is not going to cease. Fluid will again collect. So I don't think that really helps. I mean, that is what I feel.
Regarding IABP,
Yeah, IABP possibly as a temporizing measure may help to some extent, but I think, I mean, this is such an extreme situation that the only possible means of tackling it is if you can do a device closure, if you can define the anatomy, if you can possibly do a device closure. I think that is about all. I mean, most of such patients do not reach the doctors. I mean, this is such a rare case that free wall rupture has reached you because most of them don't make it to the hospital.
yes, sir. I mean, in acute stage, is it really, I mean, device closure we should attempt?
No, that's not saying as a last stage measure because I mean, no surgeon is going to touch your case.
And what about, sir, suppose we are sending for surgery immediately, then should we do coronary angiography? Because LV angio, I don't think it should be done. Giving an injection into LV when we are suspecting rupture.
That
Or
won't
it has been recommended to be, I mean, prove that there is a rupture. I don't know why. And anytime at similar time, some 1 or 2 months prior to this case, there was images in clinical medicine where they have showed one case, suspected rupture, they put in a catheter, pigtail, did a LV angio, and unstable patient died.
Yeah,
after
that will aggravate the rupture, isn't it? I mean, that high pressure injection is certainly going to
Yes.
aggravate the situation. If you're sending the patient to a surgeon, I'm sure he would certainly request at least for an angio. I mean, not a elaborate angio, 1 or 2 shots just to tell him that, I mean, supposing in this case, the LCX is the, culprit vessel. So he needs to know whether he needs to put some graft. Supposing there's a left main disease or there's a LADD disease also. He will, once he's opening up, he'll like to do a, bypass, whatever possible. The infarct related artery, I don't think it really matters in this
Yeah,
case.
it doesn't. Anyway, I mean, yes.
So I think here the first and foremost, you can have different presentations of ruptures. And in your situation, if the scenario is too dramatic, I believe straight away surgery may also be an option. But medico-legally, I think you need to define the coronary anatomy. And second thing is be minimalistic, do an angiogram, just define the anatomy and possibly send it for surgery if the patient is relatively stable for surgery. Sometimes you can have a small rupture, and I think a very good modality in such cases is a CT, which can help you. And that is something which can delineate the rupture medico-legally also. Although you know that it is a rupture in the basis of the clot in the RV side or LV cavity, whatever it is. So probably doing an angiogram, minimum amount of dye, stabilizing possibly by IABP if you feel that the scenario is there, and then a surgery for him would be the right way to go.
So yes, CAG is one thing that should have been done, no doubt. Only thing was like patient was very unstable, and it is like patient can collapse anytime. It's a small center, sir. So
we had this scenario once in our hospital, and patient was directly taken to the OT by the surgeon on the basis of a rupture he did, and we did not have time even to do an angio, and the patient survived. And it was actually a ventricular septal rupture. It was not the free wall rupture. And the patient was so sick that he had no time. The family agreed for an immediate surgery even without an angio. And patient came out, and after the patient was stabilized, then we did an angio, and there was nothing much to do. So that also can be a scenario in certain cases. So I believe it depends upon case to case.
So here, I mean, I have practically 2 fears of doing angiography, though it should, I believe, I mean, it should be done if the patient gives time anyway. So one is like, it's a small center. If the patient dies during angiography, not due to angiography, but due to whatever he has presented with. So it's like then dying during angiography is something that is not acceptable, particularly in a smaller town where. And second is, if what was the fear that if it is acute MI during die or something, if VT or something happens, then doing anything may lead to the stable clot. The patient may become unstable. So that is what I thought. And then we talked to the surgeon, and the patient was immediately taken to the OT without doing anything. I'm wasting any time in coronary angiography or anything. So within 75 minutes of patient coming to CCU, we shifted the patient to OT. And before that, fluid boluses and inotropes were given. So BP was remaining around 70-80 with inotrope support. Now this is the picture inside the OT. So there was actually 2 rupture sites on left ventricular. It was in posterolateral wall. There you can see. Sir, video is visible.
Yeah, video is visible very much.
So after cleaning, this is what it was. And this was the blood oozing out. Once they touched it, there was a blood oozing out. So this is how it was. So as a cardiologist, we are only habituated to see black blood in these things. So I thought, let's put some colorful images. So this is how it was. And it was repaired with a Dacron patch. And then the patient was shifted in a stable condition to ICU, CTVS ICU. Now, since this was our surgeon's first case also, so the complete closure was not done, and we did coronary angiography 3 days after OT. The idea of doing only after 3 days was, initially we had not done angiography, so we are not sure what lesions are there. So the surgeon said he has not completely closed the wound just because of this rupture and this thing. And as I said, it was his first case also. So if any re-exploration is needed, so for that matter, he has not closed completely. It was partial closure. And second was, like if there is some disease that is not manageable in future with stenting alone, like some very tight left main calcific, something like that, then it could have been done in the next sitting, rather than waiting for some time and then there is fibrosis. So within 3-4 days, if you are doing it, if there is a requirement, then surgeon could have done CABG. That was what the idea, because initially we are just trying to salvage the patient. The rest of the thing can be done later on. So this was the culprit, LCXOM 99% lesion. So it was left as it is. RC was having 70 to 80% lesion. So we put him on medical management. After recovery, then I think around 10-15 days later, we advised for stenting, but the patient went for this card, and after all, after 1.5 months, I did angioplasty of the RCA, 2 stents. That was on follow-up.
Patient is doing well?
Yeah, still it's more than 5 years now.
Great.
2015, so 7 years around.
Do you have any MR or something? Any severe MR or something? No.
No. So after just this patch closure, everything was all right.
Okay.
So I
Sir,
think
Sunil sir,
this is what the scenario I was also mentioning, that sometimes you may have to take the patient directly to the OT to save his life, because he is going to die from a mechanical complication and not from ischemia.
Yes, not from
And at times you may be lucky and the patient may be lucky, which happened in your case. And Dr. Hariram has put a point here that if you need to do an angiogram, then don't give heparin during the angiogram. Possibly that may
Possibly from the side of, I mean, if you're supposing you intend to send him for surgery, possibly he's thinking from that point of view.
sir, Sunil sir,
possibly
one question,
also
sir.
for the fact that Hariram can shed more light, but I think sometimes if you give heparin, the clot may actually, which has sealed it, may actually give way. And it happened to me once. I did a delayed angioplasty maybe 3 days later in a patient who came to us, and family was initially not willing, did an angioplasty of the LAD and circumflex. And immediately after angioplasty, shifting the patient to the CCU, within 10 minutes, the patient collapsed. We thought it was a stent thrombosis. This is 5-7 years back. And somehow or the other result was very good. But before taking him back to the lab, I just did an echo and there was a free wall rupture. And we actually tried to tap it on table, but we could not salvage him. And retrospectively, when we went back and looked at the echocardiogram 2 to 3 days back, there was some sort of a minor effusion which was there. And probably I can show in some of the meeting, we presented it at EuroPCR. And so what actually happened was revascularization happened, heparin was given, the contractility improved, and the clot, which was actually sealing the pericardial effusion and the contained rupture, actually gave way and the patient suddenly collapsed. So that can also happen at times. So a great case and a great recovery, Sunil. Congratulations.
Can I add 2 points, sir? This is also our experience.
Ajay?
Hello.
Yeah, Ajay, we can hear you.
Yeah. Am I audible, sir?
Sir, you're,
Yeah,
So,
you are not
we
visible
had
though.
this experience once.
I think I.
There-
This is the case that we had.
Guys.
There is some background noise.
Yeah.
Yeah, that was Sudheer.
So this is a case that we had about 4 years ago in Delhi, and this was a very VIP patient kind of a thing. When we did the angiogram, we noted that the contrast just would not clear from the wall of the left ventricle, and we realized that this is the problem, and it was 100% occlusion of the LED. But we did angioplasty. And this is a sign that's described in some textbooks, but it was actually quite reliable. We kept the patient on follow-up, kept the patient on the table for an hour, shifted him to the ward, didn't do anything. And sure enough, in about an hour, after 2 hours or so, we noticed that the rupture had begun. They called the surgeons immediately. They looked at it and they tried to salvage the patient. In another half an hour, it was a complete free rupture. So, I mean, what I'm trying to say is sometimes the hanging of the contrast in the LV wall, either in the septum or in the free wall, is a prelude to a complete tear and a complete rupture. So it was described in a textbook, but I never believed it till I saw it. Naveen sir, if you remember, this is the patient for whom the army chiefs, this was the father-in-law of that officer who was related to the army chief,
Correct.
and Duhan Saab was the commandant.
Commandant,
We
correct,
did the angiogram. I saw the 100% mid LED. I saw the stain stuck in the wall and said, "We are not going to do anything. Let's take him off the table." We called the surgeons. They were at some meeting. They took a couple of hours to come. By the time they came, it was a full, complete rupture. And then they took the patient up, but they couldn't salvage the patient. But there was a sign that was described. So sometimes on the angiogram, you can kind of prelude it. And but it's not always that this is the scenario. Sometimes if the rupture is small and it seals with a clot, the clot can become organized and form a pseudoaneurysm, which gives a little time. I mean, so the natural history. Your patient was absolutely very sick, and I think that was a perfect way to go about doing what we did. As we all know, you have a obvious tear with mechanical complication and shock. The only way to try and save the patient is take the patient to the OT straight away.
And what I learned in some of the cases was whenever you have a delayed presentation, patient is having borderline hemodynamics, delayed presentation, be very careful with your echocardiogram. Sometimes they may have a minor effusion, pericardial effusion, which your echocardiographer might miss. They look toxic. They are not that well. Their hemodynamics are unstable. So we have actually saved 1 or 2 of such patients by looking at the echo carefully and suspecting of a contained rupture and then taking them for a CT scan, proving it, and then doing an angiogram without heparin and sending them for surgery. So that is also something which we need to understand, that your echocardiographer sometimes may not be so vigilant, and at times you might be busy, you might miss it. So delayed presentations especially, look for that effusion and also for that site of rupture.
Yeah, absolutely. I mean, we have made it mandatory that any delayed presentation, the cardiologist who's doing the case himself does the echo in the cath lab before proceeding. That is very important, I guess.
And also the pain, sir. So all patients before they rupture, they will always have a second episode of pain. This is because of the stretch.
Correct.
And whatever. We keep thinking it's pericarditis, but it's important to do the echo carefully, as Dr. Samir has so clearly brought up.
It's after burning fingers.
All of us have done it. Yeah, Dr. Sunil, can we have your second case, please?
Do's and don'ts. What we should not do and what we should do.
Okay, this time.
Yeah.
So this is
Share your screen, Dr. Sunil.
yeah, just a minute. So this is one foreign body removal. Actually, 2 days back, Dr. Smit posted one foreign body removal of a chemo port. So I thought,
I think if you will allow me, I'll share that also.
Yeah, certainly. Most welcome.
So that's why I kept it. So is it visible now? This is another case.
Yeah, it's visible. Absolutely.
Yeah, and put it in a slideshow mode.
Slideshow mode. Yeah. So this is a 59-year-old gentleman has metastatic adenocarcinoma of the lung. Chemotherapy was planned and they inserted chemo port in infraxillary region. And as usual, it's a catheter from the port right subclavian main to SVC. This is how it was after chemo port insertion. So 4 weeks later, when the patient presented, the port was non-functional. So they did a CT scan. Catheter had detached from the port, and it was advised for removal of catheter. Patient did not turn up at cardiac center for next 2 weeks. Actually, somehow the surgeon was also going outside, and he did not remove the initial this thing. I mean, main port also. It had detached, so he left it and asked the patient to come after some time. So it was already 2 weeks after this detachment. So catheter has further migrated. If you see from the previous image, this was just after the detachment. It was not working. So during this 2 weeks time, the catheter has moved, and here we can see the catheter is somewhere in near SVC, and the tip, which was earlier in the SVC RA junction, has gone towards the right ventricle. So basically, it was detected at 4 weeks after the insertion, and he presented after 6 weeks. So 2 weeks gap was there. So this time chemo port was removed by surgeon, and then he was sent to cardiac surgeon for removal. So cardiac surgeon then discussed this, and we planned for a percutaneous removal. So as usual, we planned like it's a catheter, so we can remove it with snare. It was what the plan was. And initial fluoroscopy, actually, this was after wiring only that I could take. So the problem here was I was trying with a snare. So both the ends were unapproachable. The proximal end, like the SPC end, it possibly has stuck there because it is already 2 weeks. So I was not able to hold there also, not able to go near that also. The distal end, the entry, anything when I was trying to enter near that, whether it was in the trabeculations or what, it was not moving. So in the moving videos, it was like both ends are stuck. And whenever I was trying to move into RV, there was episodes of NSVT. Then I tried to pull it off, at least for a snaring, one end has to be free to snare it into the snare loop. So none of the ends were approachable. Then I tried with XB to pull it and move it here and there so that I can, at least one end should be freed. But the catheter was like XB was getting extended without this moving anyway. So then I was stuck like XB. Then I tried with the other catheter, JL with a wire. I was trying to pull it, but both ends were fixed like anything. So I was not able to make any movement at any of the ends. So that was a problem. Now, any suggestions in this scenario?
Yeah, did you try a biopsy?
No, sir. I have that, but I have never used, so I didn't try to do that.
Okay, because there you can grasp it from the that heel part. You can go from the IBC, grasp it from the heel part and try and pull it down. I mean, free the proximal end at least, or one of the ends will be freed and you may be able to snare it later. Or you can just pull it down with the biopsy also. I mean, that is what I think is possible in this case.
Possibility of cutting it into 2 pieces, but anyway, that can be
cutting, I don't know, how will you cut it?
Sir,
What about EM biopsy?
That's what I said. Biopsy forceps.
Biopsy process. Yes.
Correct.
Okay.
In fact, I also had the same difficulty. The port, chemo port was, used in the last cycle, second cycle, and the patient came for the third cycle after 21 days, and then they realized that there is a swelling at the port side, and then the port has migrated into RA. And both the ends, one end was in hepatic vein and other was in RA appendage.
Okay.
You cannot get through either of the ends.
Mhm.
But what I did, I'll try to share if you.
Okay.
So you are going transjugular or transfemoral?
Sorry,
The approach was from the femoral vein or from the.
it was from femoral vein, sir. It was from femoral vein.
So at times you can try to use a JR catheter and try to displace this.
Yeah, that's what I did.
Make
I
something
tried
free and then
to put,
probably make it move forward, backward, wherever, and then once one end is free, then you can try and snare it back.
Okay.
If at all you are able to do it.
So actually, in this case here, I tried with XB because I thought the XB loop is more acute. So I can pull it with XB and at least fix one end.
Pigtail, pigtail.
this was. I hope my screen is seen. Hello.
Yeah, your screen is visible, Dr. Smith. Yes.
So this was the chemo port, and it had both the ends which were tugged. So I initially tried that I'll put two PTCA wires, pass across the device, and then rotate the catheter so that those two wires get entangled, and then try to pull it. But difficulty was that probably it was totally abducting the wall, and two wires could not be passed across around the chemo port. But then I tried to give a tug with the catheter itself, and that caught and pulled one of the ends, and then it pulled the other end also. Here I lose this pulling with the catheter slips, but then the other end become loose, and it was easy to snare it.
Yeah, that is what I was saying. You must, at times when you don't get to the wires and just try to do something with the catheter itself to dislodge it, and so that something becomes free and then you can take it back. This is what I was trying to actually.
I tried with catheters, but yes, pigtail, I didn't try it with pigtail. So I tried with XB.
The best.
Yes, pigtail could have done.
Yeah. So there are two options here, Dr. Sunil. One is to take a pigtail. It will easily catch it and you can dislodge it from both ends. Second is to fashion, if you have a large snare, you put in a big sheath inside, leave it in the IVC, extrude your snare at a J at a right angle, take the snare across one end. From the same large sheath which you left in the IVC, you put in another wire. The wire goes on the other side of the lead. Now you pull the snare down because it will catch this wire, which is a separate wire, along with this snare, and you can bring the whole assembly down in a single shot. This is what we use when you have a lead which is broken and stuck in the, somebody has tried to cut the lead and leave a lead. I don't know if you remember, Naveen said there was one patient from Base Hospital. This is the patient who had an ICD and then had an infection, and somebody
I
had
think the
cut the lead and
lead
left
was
it.
in the right pulmonary artery, if I remember.
Lead was in the right pulmonary artery. The proximal end was stuck at the SVC, and this is actually a device which has been fashioned by the spectronetics people. It basically has a snare with a loop and another wire inside it. So you, with the one bare end of the snare, you go on one side, the other wire goes in through the other side, you pull the snare back and it catches the lead in between, and then we get out the whole system.
It has a sewing needle kind of a snare.
We can use a normal 20 millimeter snare also, sir, because it's a gooseneck kind of a thing. It comes out at right angle. You take it up, rotate it, put it on one side of this catheter. From the other side, through the same mother sheath, you take another wire, pull the snare down. It will catch the whole assembly, and you can bring it down. I don't know if I have been able to convey it.
Yes, sir. I did something similar, and I have put in a graphical also. So what you said, it is something similar, almost similar to what I did. So it was a right femoral vein cannulation. So I got to have a 14 French Moulin sheath in the cath lab. And then through that large sheath, as you said, so 4 French Amplatzer 10 into 120 Kuznick snare was there, and forwarded towards the proximal end. And so this was the initial problem. So this is how it was. So 5 French JL was taken, and once JL was across this, the wire is in the SVC. Then I removed the wire and rotated the JL so as to make a loop around. So both primary and secondary cuffs were opened after pulling out the wire, and then looped the catheter, and then again placed the wire so that it is something like this way. So through the JL, the wire came towards this IVC. Now then I put in a snare and then trapped this wire with the snare. So this is how it was. This is just a graphical I made.
Very nice.
So
Yeah, wonderful.
So another option is to use a guide extension catheter with a balloon inside it. You can take a PTCA wire through a balloon, keep it the 2 millimeter balloon inside the guide extension catheter, bring the wire back inside this, loop it and bring it back inside the guide extension catheter, and then inflate the balloon to trap this distal end of the wire. You have a fashioned loop, and that works very well. I don't know if I've made myself clear.
Another
is
thing,
for making
which
a
we can
snare.
use is are the EP catheters, reflectable EP catheters. They can be looped around and they can pull the, at least it can dislodge the, chemo port.
we don't have anyway. I mean, this was for making a snare when we don't have a snare, right?
Yeah,
Oh, this is
absolutely.
wonderful. This is wonderful.
So this is how I did. So then we trapped, making a loop, and then pulled it inside that large sheet. So this is how it came.
Excellent.
Very nice.
So this was a double loop technique. And this case I made a poster presentation in TCP 2016.
Absolutely wonderful.
So
Great.
Yeah, wonderful case. Wonderful. I mean, quick
Nice stuff.
thinking and very, very nice solution.
then
Yeah, yeah. Any comments from anyone? Ajay, you said something similar, isn't it?
yeah,
Identical, sir. Same thing only.
identical. That's it.
Yeah. Same thing only. We've done it
Correct.
several times actually. CTC has trained us very well because anesthesia residents would frequently embolize wires and catheters
Yes,
and we have
wires.
to bring them back.
Then I think
So I think, Sunil, that was the last case.
no.
No, he has prepared 5 cases, I guess.
5 cases, yeah. So basically,
great.
I have not kept all videos in one because it hangs many a time in Zoom. So I made a separate presentation so that
That's
don't
great.
get much problem.
I think we'll move to the next one, sir.
Yeah, yeah.
There's a comment from Saurabh that for the first case, reperfusion injury in immediate intervention is also a reason for free wall rupture. I think that's a valid point.
Yeah, yeah. But in this case, the 3-wall rupture had taken place earlier only. Without
Yeah,
doing
it
anything.
was just an extension of the discussion that was going on. Sir.
Very, absolutely right.
Actually, one of the fear not doing angiography was if there is a clot and if with injection it migrates somewhere and then causes VT, then doing a CPR inside the lab with a free wall rupture would have been catastrophic. That is one of the fear. So, okay.
You have to work according to your expertise and the center in which you are working and understanding those limitations.
Yes, sir. Because the main limitation was like if the patient dies during coronary angiography, that is one thing that is not acceptable in a small place. That was one major limitation, I will say.
I don't think that is acceptable anywhere. So whether it's a small place or a big place, the relatives are going to get after you.
So this was 173-year-old male deformed smoker with type 2 diabetes. He presented with acute non-STEMI. There was ongoing pain. EF was 25% and there was RWM in LAD territory. and I will just show the video. Right. So actually videos I have kept separately, so please. So is it visible?
Yeah, it's visible, certainly.
So so this was
The video is not playing, Dr. Samir.
these are not really- oh. Now
No, it's frozen.
so I have shared one this video file. So is it a static image that is appearing?
Yeah.
Sharing what? Bring your shared window to the front. Okay. Okay. Is it playing now?
Yeah, it's playing.
Okay.
Yes, sir.
So this is how it was. So I did ballooning and then this was ballooning initially with 2.512 balloon, and then it was not giving up. So I used the Wolverine cutting balloon at the proximal part where there was maximal narrowing, and thereafter we put in a 340 mm stent at a nominal pressure. Well, this is what happened after the stenting. At the distal edge of a stent, there was a rupture, and immediately the patient went into shock. So I put in a pigtail. Probably the size, the LAD was going beyond the apex towards half of the PDA territory. So though it was appearing as smaller, I thought LAD may be very big. We don't have imaging, so I put in a 3 mm stent, and that caused the almost tear at the distal edge, giving rise to tamponade. So the issue was the covered stent. We have the smallest size was 3.5 millimeter. That was the only size available with us, the covered stent. So I have to do with just a balloon inflation because the patient presented with ongoing chest pain and MI. So I was not thinking of just closing the artery. So did a balloon inflation initially for 20 minutes. Thereafter, I looked at it. Again, there was leak. It was leaking. Then distally, since it was at the distal edge, so I put in a 2.5 millimeter stent at the distal edge, and then the overlapping part I post dilated with NC 3 millimeter at very nominal pressure because the distal area was not looking that big. It was looking narrow diameter. So I put in another stent, and then this is what afterwards. So around 3 sessions of this balloon tamponading totaling 45 minutes. That is what was needed. I didn't reverse the heparin initially, but after around 40 minutes, 35 minutes, it was not going away. So before third balloon tamponading, I reversed half of the heparin. So 5,000 I reversed and then did for another 10 minutes. So total 45 minutes of balloon tamponading and it got cleared. Meanwhile, at the very beginning, I have to put in a pigtail and around 400 ml of blood was removed. I mean, it was so fast collection due to the massive rupture. This was afterwards. So there was a flow. Some dissection still appeared to be at the distal edge of another stent, but since flow was there and already, I mean, so many things have happened. So I didn't trust those areas. That RT was also very small, nothing to be put at that point, and patient has become stable afterwards. So at the distal edge of the second stent, there still seems to be looking like some dissection over there. The flow was okay. I left it.
Yeah, great. I think you were very lucky to get away with the balloon tamponade. Normally, such a large rupture doesn't respond to balloon tamponade. I mean, or has to. I think one of the possible ways, if you do not have a adequate, a stent graft, so what you can do is you can put another stent distally, and into that stent you can put the stent graft, even if the size is bigger. That will not cause at least a distal rupture or something. So within the normal stent, you can put in a stent graft which may be bigger in size, but you just you inflate at nominal pressure and it may cover the lesion. Instead of putting it in the bare artery, you can put another stent, and through that stent, you can put in a covered stent.
Okay, so even 3.5 because the
Yeah, that's what I'm saying. I mean, because if your back is to the wall, if nothing is happening, this is one possible way.
yes. Only thing is metal too much.
Yeah, no, absolutely, I agree. I mean, it is bound to reach sometimes. At least you'll save the patient's life there. Later on, you can send him for surgery or whatever.
Yes, yes. Any other approach? I mean, this was really problematic. I was there.
Yeah, this was a very large rupture.
So you were the solo operator, or did you have some colleague with you?
At this time, I was the solo operator because this was done in the evening. I was on call. We are two here, but this was done in the night time, so I was alone.
What was the first step that you did? I mean, what was the immediate first reaction once you saw the rupture?
First reaction was, sir, even then, I mean, echo machine was in the ICU. So the patient was deteriorating. I immediately put in a pigtail without even seeing the echo because the rupture was visible very clearly. And patient went into shock. So it was like this is tamponade only. So
what I'm saying is, before you put in the pigtail, is better to inflate the balloon immediately, because the more the blood accumulates, the worse the situation. Then later on, this patient sometimes go into intractable, SIRS kind of a syndrome, and they never come out of it.
So that is the first thing. You just inflate a balloon over the site of rupture and then probably do a pericardiocentesis. If you have two people, I think that helps. Ideally, it should be a ping pong technique in which you then take another approach and keep the balloon inflated and then put in another guiding, and then while the balloon is inflated, then take it. So, but alone, if you are, I think it's a hats off to you. You manage this and you worked very hard. And retrospectively, I think probably we must always probably try to slightly look at the artery in more detail and maybe undersize the stent according to the distal reference vessel diameter, which all of us agree now that once it's happened. And I think Dr. Naveen's idea is great, that you take a smaller stent and then put a larger graft master into that. So that is a very good idea.
Yeah, sometimes, sir, it is not oversizing. Sometimes even, there is some calcium and you have tried to manipulate, track the stent inside, and that probably flares up the distal edge. And when you deploy the stent, so one thing is that always check whenever you are reintroducing the stent which has past. Yeah.
There is usually a spasm component, and this RT was actually reaching. The RT was not looking like 3, but the RT was reaching almost half the PDA distal. So I thought RT may be bigger. It is due to a spasm during an acute MI. That may have, but it was a diffusely diseased RT, and that's why
I think it's always a better idea in such scenarios, maybe to undersize it by 0.25 or something.
Yeah,
And
yeah, and then
nowadays you
later
have-
post dilate. Yeah,
Yeah, post dilate, because you have nowadays stents can go up to 1.5 millimeter beyond. So
absolutely.
I mean, always look at the distal vessel. Sometimes during the intervention, we just don't focus. I mean, all of us have been doing intervention for so much of time, but I think these are learning lessons. Just look at your distal vessel. And in acute MI, patient is on inotropes and so many things. You just need to save a life. And
Absolutely. I mean,
maybe undersize it by 0.25 or.
and especially if you're working with the LCX, I mean, you tend to always tend to overestimate the LCX. So better to be conservative, put in a 0.25 SS stent, and you can always post dilate. I mean, you look at the image and then you can always post dilate. Because distal edge rupture is the most common rupture. So one should be very careful about, especially if you're using long stents, because there's a lot of taper in the arteries. So one has to be very careful with the sizing.
And good evening. So there's one more technique. This is not my idea. This is the idea from the Japanese. It's like, suppose we do not have the cover stent, the normal drug coating barrier stent. What we do, we just put the tegaderm, the sticky under the tegaderm. Just put the tegaderm over the stent and then place the stent. It just behaves like a covered stent. So one of the Japanese operator tried this in around 50 patients, and all the patients, he saved all lives of all the patients. So it just
repeat, sir. We couldn't get you.
You put tegaderm on the stent and then take the
yes,
stent inside.
yes,
Tegaderm on
yes,
the okay.
Okay.
yes, sir. This is very good technique. I tried to do it in one of my patients a few weeks back, but fortunately we got the covered stent. But this is very easy. So it's very easy. Just like in this case, it has put the uncovered stent, put the tegaderm over the uncovered, the normal the coating stent, and then we can do it.
Yeah. I think the only danger would be the tegaderm might just come off. I mean, it might dislodge somewhere.
No, sir. The sticky end, the sticky end of the tegaderm, sticky end of the tegaderm will get stick to the drug, to the stent. It will not come out.
Okay.
If you see tegaderm, sir, it will not come out.
Mm-hmm.
I also thought initially, but when I tried, I feel like it's very easy.
Is it a para stent available now? The covered stent we used to have
No,
it.
sir.
I think it's taken off. That was a very
Paras is not available.
very
Not available in India.
Not
Europe
available.
it's available, but here it's not available.
We had it for some time. We used it in RNR, and that was a wonderful stent.
Wonderful stent. Its trackability is much better than the.
Beautiful.
Wonderful.
Yeah, that's what I'm saying. Anyway, great case. Wonderful. Again, you seem to be singularly lucky, Dr. Sunil. I can tell you.
Both cases.
Sir, it is his expertise.
Yes,
and
yes,
little
absolutely.
bit of luck.
Absolutely. No, I am not taking away from his expertise. But you got to be lucky, absolutely.
Whenever we land up in trouble, he is the first one to be contacted.
I am told so. Yeah, this is so wonderful. I'm sure now I understand why.
In one of the meetings I was attending, there was one operator who presented 2 or 3 complications, and in the end he said, "Don't think that I only do complications. I do normal cases also well." So Sunil is showing all complications today. We know that he's an excellent operator, and thank you so much for sharing this. And
yes, I mean, it requires guts to share your complications there.
Absolutely.
Sir, 1 or 2 points can be made.
Yeah.
Sorry, Sunil, great case. Just one thing, this particular segment of the LAD is one segment which is very often intramyocardial. Your assessment of the vessel size may have been correct, but if that segment is intramyocardial and you put a stent there, very often this is what happens with a pre-rupture. It's not only the edge, but if that segment is intramyocardial, it may look small, it may actually be small in systole. I think you should go back to look at your cranial view and just see in case there was any small sign of a first patient in whom it occurred was somebody called Mughali, and we call it the Mughali effect after that. Every single interventionist must have seen this particular segment of the LAD giving way to a stent which we put and we feel it's not expanded, try to post dilate it, it ruptures. And then that creates a problem. As far as covered stents are concerned, the graft master is actually one stent with the PTFE covering with another stent. And that is why it's a little bulky and sometimes it's difficult to deliver in the distal circulation. So you can actually fashion a covered stent in your lab itself. You take a normal stent, you take a balloon, you cut that part, you sleeve it over the stent, open another stent, expand it, hand crimp it on top of this, and it becomes a sandwich. But this particular thing can only be used in the proximal circulation. I've used it only twice in this thing, but both times God was kind and it worked very well. Once with a 2.25 and once with a 2.5 millimeter stent. The tegaderm part also, I mean, has been reported, as he said, in from Japanese operators. Some people have again put on the tegaderm a second hand crimp stent, and that actually makes it very, very safe and ensures that the tegaderm will not go off. That means you have a stent, you put a small tegaderm, you put another stent on top of that, extra deploy it outside, hand crimp it on top of that. And that makes a perfect and a good seal. Of course, long term outcome, nobody knows, and we just want to save the life.
At least you will save a life at that particular moment.
Yes, yes,
Yeah,
Life and
that's
absolutely.
it.
life is the only thing
Great.
that comes in our mind. Okay.
Yeah.
So
Can we have your next case now, Dr. Sunil?
second, this is it visible PowerPoint?
Yeah, yeah.
Okay. So So this was 66-year-old female, diabetic, hypertensive. She had old ACS in 2010 and she underwent CABG. That time Lima to LAD and RSVG to distal RC was done. That time EF was 40%. Now she presented with LRTI sepsis and LRTI and sepsis, but she had a history of class 3 angina for past 3 months. So initial impression was like this was in 2021. So LRTI sepsis, obviously COVID was one thing. There was rest open in ICU. Initially, she was kept in COVID ward. Once it was ruled out, SRCT it was core 4. So once it was ruled out, then she was shifted out. And after 5 days of antibiotics course, then I took her for coronary angiography. There was patent lima, RC was occluded, and graft to RC was also occluded. Now, proximal LCX has 95% calcific lesion. So RCA graft was also occluded, and the native vessel has very long segment CTO from near ostium till the bifurcation. So I thought I can open at least one vessel that is proximal LCX. It was calcific lesion. So we took her. So is the video visible now?
Yeah, yeah.
Okay. So this was the angio suits. So I tried initially with just NC balloon, then angio escort, then cutting balloon, and even after that, I could not open it up. This was very much calcific, and calcium is eccentric on the one side, as you can see toward the OM side. So I used multiple angio escort, first SC balloon, then NC balloon, then scoring balloon at high pressure, then cutting balloon. There was suboptimal expansion, and then further rota, these things are not available immediately. So I left it because I have nothing more to do with such a calcific lesion. And I planned it that in the next session we'll call in rota, IVAS, and then we'll do this case. So then after 1 month, we took her for CG, this time prepared with rota. I talked with one of my friend, Nikhil, about rota, and he said maybe 1.75 will be needed. But in this case, the curve and calcium were from the very beginning of proximal LCX, and even passing a new balloon of 2.5 was very difficult. It was not tracking well through the calcific part. And the first time when I did this plastic, after removing the wire, so like removing a balloon sometimes causes the guide catheter to sink in. This was happening with the wire, and after removal of the wire had a knuckle-like thing. So calcium was so hard that it had made the wire into a knuckle. So pulling out a wire was also difficult after this first attempt. Everything pulling out a wire, and there was sucking in of this thing. So next time I planned I will not go without the mother-child system. So the plan was to go with Godzilla. and rota, and I have asked for shockwave also. So that was also there. Now the problem with this 7 French system was that we have a 7 French mother child system, Godzilla. 1.75 rota could not go through that. So either I have to do rota from directly from a catheter, but it was I mean, I'm not a, we are doing very less number of rota cases. At that time, it was less than, it was my third or fourth rota. So I was not planning to do without this thing, because even my small balloon was not going. So I took 1.5 rota. I thought maybe after doing rota and doing shockwave lithotripsy, I'll be able to open this up. So just hold on, please. Okay, so is it visible now?
Yeah.
Okay, so this time then first I did with NC balloon. There were 2 wires, so that tracking is easy. This was a 7 French system, and with a mother child system with Godzilla, so that tracking will not be affected. So first NC, then I started with lithotripsy balloon. So 6 times, so we have given 6 episodes of this 10 shocks each. It was not opening. Then started with rota, multiple passes of rota, and initially there was a drop in the rate also up to 17,000. So I thought maybe it has opened up now. So the rota used was only 1.5. That was one thing. My friend has suggested 1.75, but somehow it was not possible through the mother child system of 7, and 8 system was not available. I don't know whether 8 system is there or not, but the company personnel said that 8 system is not there. So I have to, and since it was like lithotripsy was there, so I thought I will be able to open it. Then even after rota, then I used a cutting balloon also. Again, the expansion was not that great, and the one-sided calcium, as you can see here, was persistent after that. Okay, this is another case. Okay, so this is another case. Sorry. So basically, this is what it was. I mean, even after that, this was like this only. So somehow the video is misplaced. I couldn't get that.
Yeah.
So it was not open, so I didn't put in a stent because there was residual stenosis, and I have a IBUS image, just like this. So a lot of calcium was still there, so I didn't put in a stent.
Yeah, that is a wise thing, because stent won't have expanded.
Yes, sir. That's why, I mean, even the balloon was not going. And even after this case, like when I removed the wire, and there was another knuckle at the site of maximum.
What was the size of your lithotripsy balloon, IVL balloon size?
3.5, sir.
And did you do a pre-IVUS to look at the size of the vessel?
No, sir. Actually, the balloon was also not going.
Oh, this is a huge amount of calcium.
Yeah.
And there are hardly any cracks in the calcium, if you see.
Nothing has happened, sir. I mean, in the second attempt, whatever, some dilatation was there with the first attempt. So second attempt, actually, beginning to the end, it was remaining like that only, even after lithotripsy and this thing.
Is it
So
because of,
yeah,
one of the diameter is around 4, and probably IVL may not have worked there.
No, but the maximum, this part, like where there is maximum stenosis, IVL actually needs contact with the surface. So the maximum stenosis part is hardly 2.5.
yeah.
That doesn't matter.
So this is too thick a calcium, actually. I mean, I don't think the IVL also would reach to that amount of depth. This is more than almost 5 millimeter calcium. Huge amount of calcium. So I think orbital atherectomy possibly, I mean, would be, if that is of course not available. Because otherwise, I think you've done what you could have. I mean, there's nothing else that one can offer. Any ideas for this?
Any idea, sir? I mean,
Because you've done your rota, I mean, maybe a little bigger rota per 1.75 per maybe. But you know, but
but
the calcium is so eccentric that there could be a rota bias also in this case. So it is very possible that a large bar could have just perforated the other side because your wire bias will be tremendous.
so there was a plan to do 1.75, but somehow, I mean, it cannot be done through Guidezilla. And without that, even the newer balloon was not crossing because of the lot of calcium.
So you could have platformed the 1.75 bar in the proximal circ, and then you could have taken it down from there. But what I'm saying is that it's such a huge calcium and so much of wire bias and such a tortuosity, I mean, a bend out there, it's possible that the rotabar may have, a big rotabar may have caused a problem. That is
Definitely.
also there.
Yes, sir. As I said, that was my, I think, 4th or 5th guess only. So I was not.
I think, yeah, discretion is the better part of valor.
So, as per my understanding, the IVUS showed the 2 to 3 arcs of calcium. It's not the 360-degree calcium. So, in that case, whenever we inflate the balloon, the balloon has a tendency to move towards the normal segment.
Correct.
So, right, and there are cuts. Definitely, the calcium got cut due to the cutting balloon, most likely. And the calcium, if there is 360-degree calcium, that is more get benefited by the IVL.
IVL, yes.
So there was a bias, wire bias, and your rota is going to the normal segment only. That's why it's not, and the calcium is not giving way on the normal side. The reason for not increasing the area is due to the wire bias and not due to the calcium. Because calcium is not 360 in this case. It's right around
See the depth
180.
of calcium. See the depth of calcium.
So difficult to say on IVUS.
That is okay, but you can see, I mean, it's visible on angiography.
Yes, sir, but it can be superficial calcium. It's difficult to say on IVUS depth. The arc of calcium is around 180 degree. That's why this calcium is more difficult to manage than the 360 degree calcium. This is what I feel.
Yeah, this is a very eccentric,
Yes,
chunk of
yes,
calcium
sir.
sitting out there.
Yes, sir. Yes, sir.
Very true. So
how many IVL shots did you give? You exhausted all of them? Or the...
Yes, sir.
Pardon?
6 I gave before, and 2 I have kept. If after rota I will need that, so after rota I give 2. So total 8 are there. So that was.
So you basically started with an IVL.
Yeah, I started with IVL because the tortuosity was there, and as I said, I was since it was tortuous and eccentric calcium. So I thought if it opens with IVL, then that is the most safest thing to do, rather than rota.
And sir, if we see the IVUS run also, some says that the camera or the point of the IVUS contact is also towards the normal side, not on the calcium side. So it also tells us that it may be the more wire bias in this case.
But ultimately, wire bias, you can do nothing about it.
Yes, sir. Yes.
Whatever you do, the whole thing will go towards the normal side. It will just get deflected from that calcium and go towards the other side. So that's what I'm saying. Even using a larger rotabar may not have solved the problem. It may have further compounded your problem. And fortunately, these lesions are generally stable. So even after you've done the rota, even after you've done so much of dilatation, still the lesion is stable. I mean, same thing. Otherwise, you do a rota in a normal, less calcified vessel, and you don't do stenting after that, you'll end up in problem. But such a heavily calcified lesion, fortunately they are very stable. Even after so much of tinkering around, still it is not causing acute thrombosis or something. So these lesions that way are quite stable.
True, sir.
Anything that could have been done, I mean, further.
Yeah, I think you did what you could. I mean, there's nothing else that can be offered. Seriously.
If we could have actually looked at the initial, I mean, in retrospect, I think you did whatever it was possible. It was very brave of you to do all this. But I think that if you have OCT or imaging which can actually look at the size of the vessel, probably a larger IVL, maybe because you've spent so much of an effort, and I think 3.5 was a decent size to choose, but maybe a larger IVL. That comes to my mind. I don't know, Ajay.
No, but what he is saying is correct. I mean, the IVL was very much in contact with the calcium. I mean, there is no doubt about that. In that area where the calcium is present is certainly not,
That is not 4 million.
that is not, I mean, the IVL has to be in contact. That's all. So I don't think the IVL was ineffective.
No, I think this case illustrates one of the limitations of our
Correct.
available tools in percutaneous intervention.
Correct.
There are one or two more things which could have helped Dr. Sunil.
Yes.
Right? Am I audible?
Yes,
Yeah,
sir.
yeah.
So I'll tell you how we approached a case in whom people were able to cross the wire, but they could not get any hardware across. So first, before we put him on the table, we actually did a CT scan, and that showed that the calcium was all on one side, not on the other side. So we knew that there is going to be difficult. After we had crossed the wire, we were not even able to get a 0.75 alveo or a Nick nano across it, and we used a laser. We used a laser to loosen it, and then after that, we graded the burrs gradually, went up from 1.25 to 1.75. This was an RC and not a circumflex. We went up to a 1.75. After that, used an IVL. After that, used the cutting balloon. After that, used an OPN very, very, very slowly. And then after that, and all this was done after we did the OCT after the second rota, which showed us that there was eccentric calcium and that we had shaved off quite a bit. We were confident that we would get expansion on the opposite side. You will not get a perfectly great MLA, but it's enough for you to palliate the patient for some time, and you have to get away with what you can sometimes. But I think not stenting when you're not sure is an absolutely fantastic idea. It's a great idea. What I would have done if I was in your place, once you have not succeeded the first time, I would have got the laser and the sequential rota burrs in place along with the IVL. I would have done a CT scan, which would have shown me what is the depth of calcium and what is the distribution of calcium a little bit. It wouldn't have shown whether it is intimal or otherwise, and I would have chosen OCT for an imaging. I don't think you need the guideliner for a 175 per. There is absolutely no requirement to use the guideliner. Once the wire goes, rota wire goes, after that you don't really need so much of support for a rota in such a proximal segment of the coronary artery.
Yeah, that's
If
what
it
I'm
is a
saying. Yeah.
distal yeah, you actually don't need a guideliner. On that wire, you can go with a 175 and even with a 2 millimeter burr or a 2.25 burr because it's quite a large vessel. Only you have to be very, very careful and exceedingly slow. The last thing is that sometimes when your rota burr, you go at 1.5, 1.75. We have now started doing a low speed rota. That means you actually end up getting larger MLA, especially for eccentric calcium, if you don't use a very high speed. It's slightly safer because the risk of perforation is less, and you end up actually ablating a little bit more because the contact time with the calcium appears to be slightly more. And especially across tortuous lesions, you're not worried so much about the Kokosi phenomena. But this illustrates one of the limitations of modern day percutaneous intervention, where eccentric thick calcium sometimes very difficult without orbital atherectomy to really give a good answer.
And somehow we have seen it exactly in the same location. This proximal LCX is a lot of times you had to come out and did exactly what you did, and we just couldn't do anything about that eccentric large chunk of calcium. One just came out. Fortunately, such vessels stay stable. I mean, the patient doesn't really crash when he goes back to the CCU or something. They normally remain stable.
This is usually at the area when the proximal ACS is fixed.
I don't know, but this is what I have also come across. I mean, this particular segment is where you have a lot of eccentric calcium and very difficult to
and angulation was such that, like, I have never seen that removing a wire, there was a knuckle in the wire. So
yeah, because that chunk of calcium is distorting that wire.
Yes, and the other thing that I would always use a support wire. I forgot, wanted to say that I forgot. I would never use a routine. Yeah, either a Sion extra support or a Grand Slam or something. That way, it makes it slightly easier for you to deliver your hardware and also to decide whether your balloon is expanding properly or otherwise. Because otherwise, the balloon expands and it distorts the wire exactly the way which you described.
And you can even use a, even for rota, you can use an extra support wire. There's a rota wire also, there's a rota floppy, and there's a rota extra support. But extra support reduces the bias.
Actually, the distal vasculature were small and tortuous, so I was not comfortable using any hardware.
I absolutely. I mean, the patient safety comes first.
So, like, this is how the distal area was. and there was a lot of movement with the catheter. This thing, moving anything in and out was causing wire to come out almost near to the first
No,
first opening.
supposing you had a perforation here, that would have been a nightmare.
Yes, sir. I mean, that was one reason I was not very keen for rota, higher end rota. And second was like the tortuosity was such that even I was not able to cross the balloon.
Hmm.
And so I was not sure whether if there is a rota gets stuck distally, then it will be very hard to pull. That was what. And
Yeah,
as
yeah.
I said,
Absolutely. And
not
as I
even-
said, there are limitations to modern intervention so far. I mean, this is one of them. You did the best under the circumstances. I'm sure. Dr. Smith, any comments? Dr. Samir?
I think Ajay put it very beautifully. There are certain limitations about these calcific lesions, and probably the idea of a CT scan prior to an intervention, that is a good knowledge. Then you need a very good radiologist also to look at those things, and your own eyes must be trained to do that.
Correct.
So I think great job done. And I think, Sunil, you were very, very slow, low, and you kept everything cool in your mind and didn't create a complication. So that is very, very important, that you came out without a dissection, you came out without a perforation, and you increased the luminal area. And definitely, I think the patient would have got benefited.
Yeah. The last presentation, Dr. Sunil?
Yeah, it's a small, and usually this is a which we do not see regularly. So this was post procedure. I was MLA was maximum I could get was 4.5. It was at the calcified area. And okay, so case 3 is something different. It's a 22-year-old postpartum, 1 month, 1 month postpartum. She presented with fever of 3 days and breathlessness on her exertion. She came to emergency department, and since it was just 1 month postpartum, so emergency physician suspected maybe PPCM, maybe one thing that may have been. When he did an echo, there was a massive pericardial effusion with tamponade. So went in, we started tapping 500 ml. This was the initial picture. So this is what we got. Frank pus was aspirated from the cavity, and on the first instance itself, 500 ml was aspirated. So we shifted to ICU. Initial broad spectrum cover was given. The ultrasound was showing some pleural effusion on left and some collection in the pelvis also. So the idea was to cover both gram negative since he was a postpartum, and since there was pi pericardium, so gram positive and a staph cover was a must. So initially broad spectrum cover was given. The next morning, a pigtail was put in the left pleura. A straw in the pleura there was no pus, but it was a straw colored. And after few days, after 2 days, when the cultures came in, so the this pi pericardium was showing a staph aureus that was luckily sensitive to all antibiotics. So basically it was MSSA, and the pleura that didn't show any growth. Now I have some query. I mean, this is not very usual cases. So what is the? I want to know what is being done. I mean, role of streptokinase giving intrapericardial, because we have been using it in the pleural cavity during MD days. Same intrapleural we are using antibiotics. So is there any role for STK? Has anybody used that, or intrapericardial antibiotics?
We have used it in pleural spaces, but I don't think anybody, I mean, I have not used it in a pericardial space, but that is only if you have adhesions which are there. In this case, you didn't have any adhesions per se. I mean, I think you aspirated most of your pus. But if you have, loculated things, the STK might be able to take those loculation, because it certainly does that in the pleural space. I'm not too sure about the pericardial space.
The pus was collecting, sir. Every day it was around 50 to 75 ml of pus every day for next almost 6 to 7 days.
Okay.
So there was a rapid collection of pus.
But what is the reason? I mean, was she immunocompromised or something?
No, sir, not immunocompromised. We did also a backtake and gene expert from pleural fluid. So initially, there was multiple site collections. So tuberculosis was also in mind. So we did everything. A staphylococcus was grown from here. So there was, I mean, the bacterial plus on top of that, since there were other areas, we tried to see that immunocompromise was not there, because all these things has been done. HIV.
And there was nothing in the liver or subdiaphragmatic space from where the infection was coming.
No, sir. Actually, I planned for a CT scan because ultrasound may not be giving that, but there was cost constraints, so CT scan could not be done.
Okay, because such what is the source of this pus? Primary, pericardial pyopericardium is a very rare entity.
Yes, sir. Mostly it comes from empyema, and in this case also, like the pleural effusion was exudative, though it was not frank pus or didn't grow anything, but it was exudative effusion, so possibly some pneumonia, empyema, and then it went inside. Only thing was that the pleural space was not pus; it was
Yeah, I mean I think the pleural effusion was possibly reactionary. That's all.
maybe. Yes. Actually, CT was something that I have asked on the very first day, but
We should look at the subdiaphragm because you had some cyclic fluid also in the abdomen, which is
sorry,
unexplained.
it was the pelvic collection, and that was
Pelvic.
small
Why
collection.
should you have a pelvic collection there?
Sir, that patient was postpartum for 1 month.
Postpartum.
So actually, we thought that the infection is coming from there in the first place, but it
Yeah.
was not like that. It was a staph aureus, and for PID, it's mostly gram-negative organism.
And it was a normal delivery or a cesarean or something?
It was a normal delivery.
Okay. So what did you do finally?
Yes, sir. I'll be showing here.
Yeah.
I mean, in literature, I have searched about role of a streptokinase. It is not very clear on the use, like adhesions, and those are the things that people have used. Only thing was it was once tried in 1960s, and they have some fatal complication. One out of 6 has fatal complications in children. So there was hemopericardium after use of STK. So it was almost abandoned for the next 30 years. Then again in 1980s, somebody tried again. There was one paper that has seen the role in 40 cases. The only thing is they have not made it clear whether it was PIO or a tubercular effusion. So both were combined, and what was the percentage, that was not shown. But they have said that it can be used, and now also it's saying it that if there are pus drainage is not adequate, there are adhesions, there are loculation, it can be used. So that is what intrapericardial antibiotics. Only one instance I could get. They have used intrapericardial antibiotics, otherwise not. Then usually in pus, it's a surgical drainage that is preferred, like for any other cavities. And in this case also, when I talked with surgeon, they said they need to put subdivided tube drain, because pigtail obviously is very thin lumen catheter. So for pus drainage, it may not be adequate. So these are the surgical drainage option, and most of the time these patients are toxic, and surgeon put a subdivided tube drain that can be done even under local anesthesia with sedation. So, but somehow this patient, despite having pyopericardium, this patient was very stable, not even toxic. It was just mildly toxic, what we say, and hemodynamically quite stable. So that within 2 days we shifted her to ward. Even on the very first day, it was looking like she can be managed in the ward. So toxicity was not there, and the patient was very, very stable. So in this case, and the pericardium was very thick, and since a lot of pus was coming, so I said straight away we should go with pericardiectomy. Surgeon was initially very reluctant because obviously in acute cases they are not very. He was in favor of subdivided tube drain that is being usually done by surgeons in these cases. But somehow she was a very young patient and not toxic, and then there was very thick pericardium. So I insisted on going with pericardiectomy. So initially thoracotomy was planned thoracotomy approach, but somehow the pus was kept coming, and it was very thick. So surgeon planned with sternotomy. And this is what was seen. Once the cavity was opened, it is what we call as a scrambled egg appearance of pus. So a layer of pus was there. It was like something like plaster of Paris has been kept over it, though it was, not hard, but here you can see. So it was a good layer of pus, almost 6-7 millimeter of thick pus that is all over plastered over this pericardium. And this I found in literature, it is called a scrambled egg appearance. That is what it is. Now, after they removed all the pus, and you can see the very angry looking visceral pericardium beneath the pus. It was red, though it doesn't appear mostly very light color, but as, as usual. And you can see the thickened pericardium. It is very, very thin, nearly to the thickness of the skin in both the images. If that is clear, I don't know.
Yeah.
So here the plan for total pericardiectomy, because such a thick this pericardium, that will definitely have led over to CCP, and then it becomes very, particularly after pericardium, it's like almost fixed. So it becomes very difficult to remove, and many a times there is damage to the myocardium. That is inevitable. There is perforation, and these things are inevitable. So we planned it at an early stage. Now, when doing pericardiectomy, since it was from a sternotomy approach, the surgeon is able to go even beneath it, which is not possible when they are doing with thoracotomy, and only this phrenic to phrenic approach is taken. So only anterior pericardium is removed. So when he went posteriorly, there was a strong adhesions, and at that time he was convinced that okay, need for early surgery was somehow good. So as I said, initially there was reluctance, obviously in the acute stages, but there was a strong adhesions posteriorly. Anteriorly it was very thick, posteriorly a strong adhesion, so it was difficult to remove. But since it was from a sternotomy, so I mean surgeons were very comfortable removing it. This is just for the sake of image. So all the pus was removed, and then it was closed. Maximum part of pericardium that could have been removed was removed. Most of the pericardium was removed. So it was near surgically it is called total pericardiectomy. So this is what it was. And after the operation, they usually put in a vancomycin paste over the sternum because the chance of septicemia is high. This case was done only 3 days back. So this was on Tuesday. So the patient is stable and may be shifted to ward by tomorrow. She is very stable.
You do the histopathology of the pericardium?
Yes, sir. It has been sent. It is not yet available. As that's why I said it was done.
Because such a thick pericardium with so much of adhesions, patient being non-toxic, very unusual for a staphylococcal, acute staphylococcal, pyopericardium. Very, very unusual.
Yes, sir. That is what I mean. Though it was a staphylococcus, but patient was very, very stable, and that's why I mean surgeon took the case. Otherwise, in acute stage with a staphylococcus growing, no surgeon will take the case.
Generally, staphylococcal things are the patient is generally very toxic. And the fact that the pericardium is so thick and it is so adherent, it seems more like at least a subacute process. It doesn't look like an acute process.
You don't know when it actually has started. Patient presented with only 3 days of fever.
No. If it's just staph, so it would have, it won't give you, it won't let the patient last for very long.
So we are still, not sure.
Yeah, that's what I'm saying. The histopathology would be very, very informative.
The histopathology may be available. I will share that.
We will just like to know that. Absolutely. Was it just pure staph or was staph or secondary and there was some underlying tubercular pericarditis? One would love to know that.
Yeah, that's why other things has also been sent. Gene export, backtake, we sent both because it was from the multiple sites. And this pleura being very clean means non-pus. It was exudative, but it was no pus and there was no growth from pleural fluid. So it was doubtful whether it is tubercular or not. So we have sent those things also. That were all negative. Tubercular workup was negative.
Okay.
Histopathology is awaited. Maybe by Monday I will get that.
Yeah. We'd love to please share that.
Yes, sure, sir.
Any comments, Dr. Samir, Dr. Ajay?
I think a very great case and still have a diagnostic dilemma, as you rightly said. I remember one patient who was a young boy, 12 years of age, 10 to 12 years of age, 7-8 years back, who exactly had this kind of a drainage. He was staphylococcal, obviously, responded very well to vancomycin. We see sometimes in the pediatric or adolescent, but this 22 years and that kind of a relatively non-toxic staphylococcal, unusual, but we do get those things in medicine. So I think it would be really interesting to know the histopathology and maybe a whole body PET CT or something after the patient.
Yeah, we should go into a little more depth.
Yeah.
Very true.
Yeah, I think great point, sir. Just two things. Number one, I think surgeon was very kind to go in without a CT scan. I think a CT of the chest as well as of the mediastin would have been absolutely mandatory before they went in, instead of finding some other surprise. And I completely agree with Naveen sir. It is extremely unlikely that this is pure staph. Most likely, the patient has underlying tuberculosis, had little bit of tubercular pericarditis, and has got super infected with staph
Just have to
on top of that. Most likely, maybe a small pneumonic effusion, and that staph has got walled off on that acutely inflamed, subacutely inflamed pericardium, and then thereafter it has just kind of walled itself off as staph does, and has grown, and then patient has come to you acutely. As you said that after you drained and took away the tamponade physiology, probably she was not doing so badly after that. And it will just continue to drain because it's a completely walled off thing. But I think a CT prior to a surgery would have been probably mandatory, however difficult and this one it was. Even now, I feel it may not be so difficult. Probably the CT is very, very important because if you have parenchymal involvement, you have to work very hard to look for tuberculosis. From pleural fluid, it's very difficult to prove sometimes.
Yes, sir.
But it may be easier with a nebulized sample to get some gene expert on sputum and find it. And probably the other non-invasive markers will help you, because if she still has untreated tuberculosis, she will still end up with a problem at the
I'm
the
sure the
PET is a great.
histopathology would help us, sir.
Yes, sir. Yes, sir. I'm sure. But knowing, having worked with pathology for so many years and pathologists of varying skill levels and this thing, they're likely to give a please correlate clinically type of report, and then we're stuck where we were. So
What was the
I
ADA
really
level, adenosine deaminase level? Did you look at that in the pericardial fluid?
That was high, but for pus, actually, it doesn't matter. For
Not
pus,
it is
it
not,
always be high.
not very reliable. No, for this
Hmm.
kind of a patient, you will have to demonstrate proof of tubercle bacilli,
Yes, sir.
either with a gene expert or with I don't know that the
So that
the serology. Yeah,
gene
please.
export was done, sir. That was negative. Gene export and backtake both we have done. Backtake is awaited
No,
culture.
but I mean, gene expert is very good for sputum. It is not so brilliant for
Yes.
so many other other these things, and that is why, because of the staff, you may not get such a fantastic report from the pathologist. They will give you, please correlate clinically if you granuloma seen, and you are exactly where you were.
No, no,
I think you
Ajay,
have to fall back on.
I hope there is no pathologist or nobody has a spouse as a pathologist.
No, sir,
Just
I
for
am
the
married to a
interest of,
microbiologist.
other than a query from my side, do we have gamma interferon in pericardial fluid assessment available in India and some centers? That is said to be better than ADA for tuberculosis, just out of the.
All these newer methods, they are based on gamma interferon only.
All this TB gold and all is gamma interferon only.
Gamma interferon only.
Yes, yes.
Yeah,
Gold
true, true.
quantiferon is gamma interferon.
Yeah.
But in an
TB gold.
acutely inflamed pericardium, it may not be so may not be so indicative. We have to fall back on microbiology. My wife is a microbiologist. That's how I know. She keeps abusing all the clinicians left, right, and center. But you people don't know what you're dealing with. So
Pathologists
some
may
of us
not
like
know, but microbiologists definitely know.
They will know.
So,
Great cases here. Very unique cases, Dr. Sunil. Amazing. What a fantastic presentation. So thank you, Dr. Smit, for arranging all this. And I'm sure all of you must have equally enjoyed as much as I did. And of course, with the beautiful comments coming from Dr. Samir and Dr. Ajay and Dr. Smith, it was worth the while. Thank you everyone for attending, and thanks a lot, Sunil, once again. And please do share the histopathology report as and when it comes.
Sure, sir. I will
It'll
share
be,
in the group.
it'll be really an educative case. Thank you everyone, and have a great night. Enjoy yourself, and hope no primaries in the night.
For the next month,
Thank
we
you,
have,
sir. Thank you, sir.
Thank you. Thank you.
Dr.
Bye-bye. and good
Anupam
night.
Jena, he has agreed to present his cases, what he has presented in the for the Chinese presentation.